Good morning. Thank you for joining us today. The topic of the webinar today is Cleft Lip and Palate. We'll be covering all of the information that we generally provide to our parents at their initial prenatal visit with our Cleft team. So in effect, today we are having a virtual Cleft prenatal visit. I hope that this session is informative for you and generates more questions that you can then bring to your next visit with our Cleft team. So let's get started. First, I'd like to introduce myself as your host today. My name is Dr Greives, and I'm a fellowship-trained craniofacial and pediatric plastic surgeon. Here at Children's Memorial Hermann, I specialize in the treatment of children with cleft lip and craniofacial anomalies, including craniosynostosis, and help run both the cleft and craniofacial team as well as the vascular anomalies team. I am also part of a larger team of providers who comprise the Texas Cleft Craniofacial team. Working with this multidisciplinary team of professionals gives our patients the comprehensive care that all patients deserve, and we're going to be talking a little bit more about the team care later in this webinar. I'm fortunate to work at the Children's Memorial Hermann Hospital, located in the heart of Houston's Medical Center. As a partner with the University of Texas Health Sciences Center at Houston Medical Center, Children's Memorial Hermann can provide the highest level of care for the children that we treat on a daily basis. So for the topic of our talk today is what do you do as parents with a new diagnosis of cleft lip and palate, or basically what to expect when you're expecting. This talk will function similar to a prenatal visit with our cleft team, or if you found out the diagnosis after the birth of your child, we'll cover the topics that we generally cover during your first visit with us. For the outline of our talk today, we'll start with a little background and classification of the types of clefts. We will then discuss the team care concept and introduce you to the people who make up our team here at Children's Memorial Hermann and the Texas Cleft and Craniofacial team. We will then focus on feeding issues and the bottles that we use and are needed for cleft babies. There's also a small segment on speech, and then we will finally discuss the surgical plans for all of these patients. So let's get started. Cleft lip and palate remains one of the most common birth defects, with over 4,000 children born annually in the U.S. alone. Ethnicity plays a role in its prevalence, with patients from Latin or Asian backgrounds having higher than average risks, and those from African heritage having a lower overall average risk. Male infants have almost 2 times as high of an incidence of cleft lip compared to female infants. However, the risks are reversed, with the risk of cleft palate alone being higher in the female patients. While genetics do play a role in some cases of cleft lip and palate, most cases are sporadic, meaning they randomly occur throughout the development of the fetus while in the uterus. Family history, or relatives with cleft lip and palate, is one of the strongest links to risk for having an infant with cleft lip and/or palate. The most common syndromes associated with cleft lip and palate are van der Waals syndrome, which involves cleft lip and palate and small salivary gland masses on the lower lip. This is inherited directly from a parent, though some cases of random mutations do occur. Also, Stickler syndrome, which is a mutation in the production of collagen, often produces a cleft of the palate. Most teams would recommend a genetic consultation for any patient with a cleft lip and palate to rule out other anomalies. The environment has also been implicated in the development of cleft lip and palate. In particular, smoking and alcohol use during pregnancy, especially in the first 8 weeks after conception, when the fetus is developing facial features, has been associated with the development of cleft lip and palate. Certain medications, particularly anti-seizure medications, have also been shown to increase risk for cleft lip and palate. You should always discuss with your doctor and obstetrician any medications that you are taking to determine if they are safe for you to use during pregnancy. Historically, diagnosis of the cleft lip or palate occurs at birth, when a full physical exam of the infant is possible. For some of you listening, this may have been how you found out about your cleft child. Advances in ultrasound technology and prenatal MRI allow significantly improved details in the detection of fetal anomalies that were previously unable to determine. However, some children, especially those with an isolated cleft palate or a small cleft of the lip, are missed on routine physical ultrasound. As technology is rapidly improving, the detection rate for these anomalies continues to improve. So the biggest determination of what the course of your child's care will be the diagnosis of the type of cleft. Clefts of the lip can either be unilateral or on one side of the face, as shown here on the left patient. They can also be bilateral or on both sides of the lip, as shown on the patient on the right. The central mass or prolabium that you see projected on the right patient is rotated outwards, and it is very common for patients with bilateral cleft lips. This will need to be reduced and repaired at the time of the lip repair. Clefts of the lip can either be incomplete, meaning they only extend part of the way of the lip, but not all the way up into the nose, as we see in the patient in the left, or they can be complete, as we see on the patient on the right, where the cleft extends through the entire lip and up to the base of the nose. As you can imagine, the repair of the complete cleft lip and nose is a much bigger affair than the incomplete lip, and we will discuss some techniques later that will help us in this process. For the palate, any portion of the palate can be involved. On the left, you see a patient with a complete cleft of the palate as well as the lip. This cleft extends from the soft palate in the back all the way through the hard palate to the gum ridges or alveolus. In the right, we see a patient with an isolated cleft of the soft palate. Both of these will need to be repaired, but obviously to a different extent. The biggest thing to realize about the cleft of the lip and/or palate is that these combinations can occur in any variation. Each treatment plan is therefore individualized to your child's particular defect and what needs to be done to best care for their unique cleft. So now that you know a little bit more about what the clefts look like, I wanted to discuss how we care for them and who the members of the team are that you keep hearing so much about. A cleft team comprises many specialties, from nursing to therapy to surgeons and dental professionals. Each member plays a critical role in the care of the patient with a cleft lip and palate. Many centers, such as ours, have cleft teams where patients come annually for an evaluation with the entire team. This one-stop shop minimizes patient clinic visits, which can become taxing for the families, but it also allows us as team members to discuss our care plans directly with each other and come up with a more comprehensive plan for each of our patients. The central figure in any cleft team is the team coordinator. This is the person with whom you will have the most contact during all of your time in clinic. They coordinate all the prenatal and postnatal visits. They ensure that you have the correct bottles, help with enrollment in speech or other services, and provide access to the entire team for the families. In our team, we are fortunate to have a fantastic provider, and as I tell all of my patients, everything runs through Leanne. Our surgical team is comprised of a few different types of surgeons. Our cleft team is run by Dr. John Teichgraber, and together we are the plastic surgeons for the cleft and craniofacial team. We perform the repair of the cleft lip and the cleft of the palate. We can also perform the bone graft to reconstruct the gum ridge or alveolus, as well as the orthognathic surgery on the jaws to fix the occlusion of the teenage child. And finally, we perform any rhinoplasty or nasal surgery needed to complete the reconstruction. And we will discuss all of these surgeries later in the webinar. Our ENT surgeons, Dr. Roy, Dr. Yuxel, and Dr. Jang, assess all of the infants for breathing and airway issues. Almost all children with clefts of the palate have issues with ear infections and require tubes placed to drain any fluid collections. Our ENT team performs these surgeries for our cleft patients and also monitors their hearing function with audiology exams. Dr. Jamie Gaetano is the other co-director of our cleft team along with Dr. Teichgraber. As an oral surgeon, he also performs the alveolar bone grafts and orthognathic surgery needed for these patients. When most people hear orthodontics, they think of braces. Most cleft patients have very disorganized teeth and even are missing some of their adult teeth, so subsequently they will need braces at some point in their teenage years. Dr. Ellis and his team do indeed perform braces and adjustments of the teeth for our cleft patients. They also expand the palate to create a symmetric and appropriate bite, as well as assist in the planning for jaw surgery later in life. Pediatric Dentistry helps take care of the cleft patient's teeth, including cleaning and monitoring for any issues with the teeth. Our dentists here also perform Nasoalveolar Molding, or NAM, for our complete cleft lip patients to assist in our cleft lip surgeries. We will be discussing the NAM process a little later in the webinar as well. Because of the abnormal anatomy of the cleft palate, many of these patients require speech therapy to improve their overall speech. Our therapists also work with the newborns and their parents to ensure proper feeding techniques are used to ensure the best quality care for the cleft babies. For older children with speech issues, they also perform our imaging studies such as nasal endoscopy to evaluate the speech function and need for other speech interventions. And our genetics team and counselors provide the families with information regarding their diagnosis, as well as risk assessment for future children. They also perform genetic testing for families and provide them with counseling regarding their diagnoses. So now that you've met our team, the biggest issue and most frequent questions for many new families is, what do we do with feeding? Babies born with a cleft palate are unable to form any oral suction due to the opening in their palate that extends into their nose. This prevents them from adequately nursing and requires them to be bottle fed. However, most standard bottles require babies to form some form of suction to induce feeding. To improve cleft feeding, a few specialized bottles and nipples have been developed. The Hermann, as shown here on the right, is the most common and has a soft reservoir and tip. The nipple is placed in the infant's mouth and the soft reservoir is squeezed to squirt the milk directly into the baby's mouth. This overcomes the need to form any suction for the cleft infants. Other feeders include the pigeon nipple, as shown on the left. Pigeon nipples are mostly used for cleft palate alone babies. The mechanism works by the baby putting pressure on the nipple, either with the gums and/or tongue, and the milk is then expressed. On the right, Dr. Brown's special needs feeder is a newer system. Everything about the bottle system is the same as a normal bottle, but with the addition of a one-way valve. For more specific information on the use of the bottles and to see videos of feeding a baby with these bottles, you can go to www.cleftline.org, which will be included at the end of this webinar. Or for more specific information, you can call your Cleft Center or speak to your Cleft team coordinator. So as we mentioned before, speech therapy is essential to all cleft children's care, and I wanted to discuss a little bit more about why this is an issue. Briefly, in a normal palate, as seen on the left, there's a muscle called the levator veli palatini that crosses the back of the soft palate and helps elevate it to close off the nose when speaking. In a cleft palate, on the right, this muscle is broken into two parts and doesn't function properly. Air escapes up the patient's nose and creates the typical hypernasality of speech that is commonly associated with cleft children. During the repair of the cleft palate, not only is the defect of the cleft itself closed, but the muscles are repaired so they function again. Children are then assessed annually at our team visit for their speech quality and any evidence of hypernasality. If needed, home-based or school-based therapy is then initiated. If problems with speech persist despite therapy, additional imaging, such as a palatal motion study or nasal endoscopy, can be used to determine the cause of the speech problem. And finally, in some cases, additional surgery to improve the speech function may be needed to improve the function of the cleft palate. So, after all that, we can finally get down to what it is that I do and discuss what it is to expect from surgery. This represents a typical timeline for patients with cleft lip and palate. Now again, as every cleft is a bit different, not everyone needs to have all of these surgeries done. For example, a patient with only an incomplete cleft of the lip may only need to have the lip repair surgery, while a complete bilateral cleft lip and palate patient will likely need all of them. An assessment is made annually at the cleft team visit, and any suggestions for surgery are discussed with the team and the family at that time. Prior to the surgery of the lip, presurgical molding may be used. The most common is Nasoalveolar Molding, or NAM therapy. This is performed by our dental team and uses a custom oral splint that molds the two sides of the gum ridges back into their normal alignment. They then add a nasal stent to help align the cartilage of the nose and taping across the upper lip to reduce the width of the cleft lip. NAM requires weekly appointments with the dentist for adjustments and is initiated around 1 month after birth. The appliance is slowly adjusted and parents perform the taping at home as needed. As you can see here, the nasal stent has been added to improve the overall shape of the nose. Overall, NAM takes between 2 and 4 months to complete and is done prior to the cleft lip and nose repair surgery. Here's the progression of the gum ridges and how NAM can affect them. As you can see, the splint slowly narrows the cleft, making the gap repair smaller and the surgery easier. At the same time, the lip is taped to improve the width of the cleft lip margins. While it's hard to imagine, this is the same patient at 1 week after birth on the left and at 4 months of age on the right after his NAM therapy and just prior to his lip repair surgery. You can see the dramatic improvement in his nose and lip shape after this therapy, and it sure makes my job as a surgeon much easier. Another option for presurgical molding is a two-step surgery called a cleft lip adhesion. In this case, a first surgery glues the two sides of the lip together to reduce the size of the defect and passively close the defect. In the second surgery, a definitive cleft lip and nasal repair creates a complete repair. While this requires a second surgery, there's no appliance, office visits, or taping needed. Here at Children's Memorial Hermann Hospital, we offer both NAM therapy and cleft lip adhesion to all of our patients, and then help them decide the best solution for them and their child. When we get to the time for surgery of the lip and nose, we aim for about 3 to 6 months of age. The surgery is about 2 hours long, and we plan for the child and parents to stay in the hospital overnight to make sure their pain is well controlled and that they are drinking to stay hydrated. The children wear elbow immobilizers to prevent them from sucking their thumbs or ruining the cleft lip repair. They also all wear nasal stents as shown to help mold the nose into its final form. So here are some before and after examples of some of the clefts that we've recently seen. This is an example of a unilateral, complete cleft lip before the surgery on the left and a few months after the surgery on the right. You can barely see the scar, and the lip and nose show excellent symmetry and balance. Again, this is our little boy who completed his NAM therapy, and here he is on the right after his lip and nose repair. It's hard to imagine getting this excellent of a repair without the hard work of our dental team and the parents prior to completing his NAM at home. This little boy with a complete unilateral cleft lip and palate underwent a two-stage surgery with a cleft lip adhesion first, followed by a cleft lip repair. As you can see, he has a fantastic final result that many people wouldn't even recognize that he had a cleft to begin with. And finally, an incomplete cleft lip before on the left and after on the right. Because she was incomplete, she did not have any NAM or cleft lip adhesion, and this was done in one surgery with a great result for her nasal and lip balance. While harder to see in photos, the cleft palate repair is critical for feeding and speech in these patients. We perform our cleft palate repair around 12 to 18 months of life in a one-stage surgery. The goals are to close the cleft of the palate and to repair those muscles which we talked about previously. The cleft palate repair takes between 2 and 3 hours. The patients generally stay overnight again in the hospital to ensure they are breathing well, their pain is well controlled, and that they are again staying hydrated. They will again wear the elbow immobilizers to prevent any fingers or toys from getting into their mouth to tear the newly repaired palate. Again, here you can see a normal mouth on the left, a cleft palate in the middle, and following the repair on the right. The repair that is shown is called a furlough palatoplasty, which both lengthens the palate and repairs the muscles at the same time using a Z-plasty. This can also be done secondarily for patients who have persistent speech issues after their primary repair, or if there's a fistula or hole in the palate that needs to be repaired secondarily. At the time of our cleft palate repair, our ENT team evaluates the infant's ears and usually places myringotomy tubes in their ears to help drain any fluid from the middle ear. These are monitored by the ENT team and replaced if they fall out or if the child develops fluid after the first set of tubes. After the palate is repaired, there's a long break from surgery. The children undergo speech therapy as needed during this time. Around age 7, the patients enter their first round of orthodontics and the palate is expanded. After this, the defect in their gum ridge or alveolus is repaired using some bone taken from their hip. This allows the upper jaw to finally be a single piece and helps the adult teeth erupt into the correct position. Again, only patients with clefts of their alveolus need this surgery. In the teenage years, we start watching the teeth and the occlusion between the upper and lower jaw more. often in cleft patients, the upper jaw doesn't grow as well as the lower jaw. Orthognathic surgery treats this misalignment of the jaws by putting the teeth into proper occlusion. This generally happens in later teenage years once the child is done growing. And finally, any revisions to the lip or nose can be made at the time of the rhinoplasty. As you have seen from the infant's pictures, the nose is twisted and the cartilage is deformed from the cleft. The rhinoplasty surgery straightens the nose, improves the breathing, and gives a final aesthetic refinement to the face to complete the lifelong process for our cleft patients. So in conclusion, I hope you have a better idea of the pathway for our patients with cleft lip and palate. If you are expecting, I recommend that you please schedule a prenatal visit with us and we can answer any additional questions that you have. We also recommend finding good resources online, social media, or even other parents through blogs and other mediums. Our Cleft team can put you in contact with other parents who have proven to be valuable resources for our families. And finally and foremost, congratulations on your new child and welcome to the Cleft family. Here are some sites and resources that you can access for additional patient information, stories, contacts, and links. And again, the cleftalign.org is excellent for additional feeding issues with the bottles previously shown. So thank you very much for your time today. I hope that you learned a little bit about what to expect, and if nothing else, generated more questions to ask when you next come in for a visit. And please feel free to call and schedule an appointment to see us at the Texas Cleft-Craniofacial Center at Children's Memorial Hermann Hospital and the University of Texas Health Sciences Center at Houston. We look forward to hearing from you soon.